Trying to record. All right, we are recording then. So we'll back to screen. All right, Woods, I'll turn it over to you here.
Thank you so much, Dr. Nichols, and thank you all for joining me. I'm so grateful to Dr. Nichols for running this group and organizing it for so many years now, and for all of you for participating. I think that engaging with our patient community is so important, and it's really, truly one of the strengths of our bone health program here at UCSD. So thank you for joining me. Today, I'm going to be talking about something that's not really specific to bone health or osteoporosis, although it certainly is relevant, but I think this topic could apply to many medical conditions, and that is the medical mindset. So we'll be talking about what it is, defining it, kind of talking about the different types of mindsets, and how we might use this framework to communicate preferences when it comes to personalizing treatment for osteoporosis. So I do have a few financial disclosures, but probably more important for the purposes of this talk is based on a book, and I didn't write the book. So I did read the book twice, actually, but I didn't write it. It was written by a husband and wife team, doctors Pamela Hartzband and Jerome Groopman. Dr. Hartzband is an endocrinologist. Dr. Groopman is a hematologist oncologist. They practice in Boston. And also, I'm not a psychologist, so this talk will cover some psychology concepts, and I have consulted with psychology colleagues, but that's a little bit outside my area of expertise, so I probably can't talk in detail about some of those topics. So the objectives for the next 45 minutes or so are to, first of all, recognize that most individuals with osteoporosis are untreated. So this is not something that is talked about enough, in my opinion, that the majority of people in the US and probably globally that have osteoporosis are on no treatment at all. The second objective is to understand the medical mindset model. So this is a framework that I will describe, and it's one that we can use to communicate between patients and healthcare providers when it comes to understanding values and preferences. And then third is to consider using this mindset model to communicate your values and your preferences in the healthcare setting. So just to take a step back and look at osteoporosis from a public health standpoint, it is a major public health problem. We know that 1 in 2 women age 50 and older will have a fracture in her lifetime. 1 in 2. That's hard to think of a condition more prevalent than this. We're expected to have 3 million fractures in the US next year, 2025. And that will result in $25 billion in healthcare expenses. So a huge cost to the healthcare system. And for those individuals, those 3 million individuals who suffer fractures, a substantial burden of disability, reduced quality of life, and even earlier mortality. So we have multiple therapies that are all effective for preventing fractures in individuals with osteoporosis. And yet this care is not being delivered. So we've had truly a boom in drug discovery. We have 5 different classes of approved medications for osteoporosis. And yet, you know, the majority of patients with osteoporosis are on nothing at all. So at last year's American Society for Bone and Mineral Research meeting in the fall of 2023, there was a poster in the poster hall. It wasn't a major podium talk. It was just a poster tucked away in the corner of this big, huge poster hall, but it was the thing that struck me the most from the whole entire meeting. So this was a retrospective cohort study using an administrative claims database. So they looked at about 9 years of data and identified almost 500,000 women age 50 and over who had an initial fracture. And then they looked at the rates of having a second fracture within 24 months of that index fracture. And they also looked at rates of treatment for osteoporosis. And what the authors found, so I know this slide is a little busy. So these graphs are showing the incidence of a second fracture after that initial fracture. And they broke it down by if the index event was any fracture, hip fracture, any what they call major fracture or a clinical vertebral fracture. But whatever type of index fracture we look at, let's start with the any fracture here. Within 2 years of having one fracture, there's a 19.1% rate of having any kind of other fracture. There's a 7.8% risk of a hip fracture within 24 months of any fracture. So these are all what we would consider very high fracture rates. 5% risk of a spine fracture. The highest was down here when we look at those who had an index spine fracture. Within 24 months, they had a 27% rate of having a second fracture, 23% rate of a major fracture, 15.9% risk of a rate of having a second spine fracture, and almost 7% risk for hip fracture. So these are very high fracture rates. So what about treatment? At 12 months after the fracture, only 8% of women were on any treatment at all. And within 24 months, 10% of women were on anything. So 90% of women are on nothing for osteoporosis within 24 months following a fracture, women 50 and over. So we are really failing to deliver these effective therapies that we have when we look at it from a big picture standpoint. So what is going on here? We'll talk about that a little more. Looking at our data from UCSD, we are trying hard to improve our screening and treatment of osteoporosis. So this is by quarter 2023. Here's quarter 1 of 2024. The most recent data collection we have was that we are screening 80.5% of women with bone density scans. Those women who should be screened, we're screening 80%. So that's pretty good. Not perfect, but not too bad. We are correctly documenting the diagnosis when they have it in about 68.7%. So again, we could do better, but it's not terrible. But this is where things really drop off. So when we look at treatment rates, so in women who have a documented diagnosis, so these women here, only 45% of them are on any treatment. So we're making small gains, but we are still less than 50%. So even at UCSD, it is true. The majority of women with osteoporosis are on no treatment at all. And following a fracture, unfortunately, we're at 29.4% within 2 years following fracture. So that's almost 3 times better than the national average. So relatively speaking, we're doing well, but from an absolute standpoint, this is still terrible. We know these individuals are at the highest risk, and we are not even treating 1 in 3. So I would say we have a lot of treatment available for osteoporosis. Anything is better than nothing. So I think, when I go to talks on osteoporosis treatment, sometimes I feel like we get too hung up on why one drug may be better than another, but really all of them are effective and anything is better than nothing. So why are the treatment rates so low? One is we could be failing to diagnose osteoporosis. We could be failing to order the DEXA scans. We're doing pretty well. I showed you 80% at UCSD, so I don't think this explains all of it. I do think failing to recognize fractures as a sign of bone fragility is still a problem. Many individuals say, well, I fell because of, there was a high force injury. My dog pulled on the leash and certainly that will generate more force associated with a fall, but anyone age 50 or over with a bone fracture should get a bone density scan just to assess their bone health and make sure, that this fracture wasn't a sign of bone fragility, because we know that one fracture leads to more fractures. Are our rates low because we are not offering treatment? This could be a problem. So we know that there's a lack of access to bone health specialists. As you all are aware, there are very long wait times to get into our osteoporosis clinic. We are trying to improve that, but the simple math is that there are far more individuals with osteoporosis than there are specialists in this field. So we're going to need to get creative about how we can deliver care to more people efficiently. And primary care doctors are overwhelmed. They don't have enough time. The care is getting more complicated. So we're going to have to really innovate some solutions to deliver care. A third option is that care is being offered but not accepted. And I do think this is something that we see commonly. Patients are reluctant to take the medication, and we'll talk about why that may be. And finally, treatment may be initiated but then discontinued. So let's get into a little bit more about how we can decide on making a treatment recommendation. So the American Association for Clinical Endocrinologists, ACE as they're called, they have guidelines for what they call PMO, postmenopausal osteoporosis. And in those guidelines, they say that they allow physicians to individualize treatment decisions for patient preferences and circumstances. So they do acknowledge that we should be individualizing our recommendations, but this is just a one-liner. There's really no guidance on how to do this. Similarly, the Endocrine Society says decisions regarding the choice of therapies must take into account the country-specific availability of the drugs, local guidelines, values and preferences of the patient, costs, and drug coverage. But again, this is a one-liner with no details about how to assess these values and preferences. So how do we communicate these values in the healthcare setting? This, I have to say, honestly, is not something that I think is well taught in medical education. And it would be of benefit, in my opinion, if healthcare providers and patients could share a similar language and way of communicating these preferences. Two ways that I see this being done, which I think neither of these are particularly effective. One is the menu model, where patients are given a menu of options. We have a weekly tablet, an annual infusion, a once every 6-month injection, a daily injection, and they're asked to just choose which one they want, but nothing, no one isn't recommended over another. And then an opposite approach is where a healthcare provider may say, you have to take this one. This is what you need to do because you have osteoporosis and you had a fracture, you have to take this particular treatment, and maybe the patient doesn't feel like that's a good fit. So neither of these are really an effective way to communicate values and preferences. So I read this book about over a decade ago, actually, called Your Medical Mind, How to Decide What is Right for You. And I do recommend it. It's actually written for patients, not for healthcare providers, but I think everyone would benefit from reading it. And they describe this medical mindset model. So we'll talk about this in the next few slides. So they break it down into different categories. So one category of mindset is the maximalist versus the minimalist. Another category is someone who has a naturalism orientation versus a technology orientation. And then the final category is someone who's a believer versus someone who is a doubter. So in the next couple of slides, we'll go through each of these one by one. So the maximalist versus the minimalist. So the maximalist is the person who wants to be proactive. So they want to stay ahead of the curve. They are willing to do everything and more to really stay on top of their bone health. So these patients, it's funny, I used to think that I've been thinking about this mindset model for a while in different patient encounters, and I used to think that men were more likely to be maximalists. But then I realized that men are not routinely screened the way women are. And so the men who make it to my clinic are the men who are the most proactive. So I think that that is a selection bias. So these are individuals, and maximalists could be men or women, but people who really want to be proactive, maybe they advocate for themselves to get a bone density scan before their doctors even recommend it, or their bone density, maybe shows early osteopenia, but they want to see what they can do to reverse it. And they're willing to do anything and more to stay ahead of things. Whereas the minimalist is someone who really prefers to avoid medications if at all possible. And I recognize the minimalist when someone says to me, I know I have osteoporosis on my bone density scan, but I'm not ready to go on medications. I really don't want to do that until I really need to. So this person really values not being on medications or taking the minimum amount of treatment that's necessary. So that's the maximalist versus the minimalist. When it comes to naturalism versus technology orientation, someone who has a naturalism orientation prefers treatments that are derived from nature, and they believe in letting the body heal itself. Whereas someone who has a technology orientation may be more interested in the latest scientific advances. They may be more interested in, scientific breakthroughs and new treatment modalities, including medications or other therapies that are more technologically based. And then when we talk about believers versus doubters, this is not believing in any particular thing. These mindsets can come in different combinations. The believer is someone who makes their decision and proceeds with confidence. So they're at peace with their decision. Once they decide how to proceed, they go ahead and they don't look back. Whereas the doubter, as the name implies, they have a lot of doubts. So they may have trouble making a decision, or they make a decision and then second guess themselves frequently. They kind of read all the package insert, or now it's all online. They look up the medications online, read, different things probably on Facebook and what have you, and worry about all the possible adverse effects. So they kind of are more ruminative when it comes to decision making, and they second guess themselves a lot, or second guess the treatment plan. So treatment strategies for maximalists. When it comes to bone health and osteoporosis, maximalists, they want the best results and they're willing to do whatever it takes. So the good news is we have a lot of tools in our toolbox, and we have some very effective medications. So maximalists may be open to our bone builders. They may prefer, in fact, the bone building medications, our anabolic agents that are the most effective at improving bone density and reducing fracture risk. They may be totally fine with being on a sequence of therapies in order to get the optimal results. They may even be interested in combination therapy, which is kind of pushing the envelope on that is not something that's generally approved at this point. There have been some studies on it, but it's kind of like not really mainstream just yet. So that's one of the challenges, is that sometimes maximalists may push the limits of what's been commonly accepted or the FDA approved indications. And in general, according to Dr. Hartzband, the maximalists may be slightly overtreated when we look at what the guidelines would suggest. And then conversely, the minimalists, they prefer less frequent medications. So bisphosphonates, which allow patients to take holidays from treatment, may be something more that a minimalist may prefer. You can take a medication for a few years and then come off of it for a few years. They may prefer denosumab, which is just every 6 months, one sub-Q injection, rather than something that would be, say, a daily injection. The biggest challenge in treating minimalists for osteoporosis is that minimalists often don't want to start treatment at all. And so then the question is, when I hear patients say, well, I don't want to start treatment until I really need to. So what would be the point at which we define really need to? So what would be the threshold at which the individual would feel that they need to? And what we don't want that threshold to be is to have a fracture, because I do see lots of women who come in and have had spine fractures or hip fractures and really are suffering from the implications of those fractures. And so we want to help the minimalist to choose a threshold that would not be having a fracture. We want to intervene before we get to that point. And then when we talk about those with a naturalism orientation, these individuals may prefer hormone therapy over some of the other medications. Hormones are often perceived as natural, and so patients who don't want to take other medications may be open to taking hormones. The limitation, of course, with hormones is that there is sort of a time window in which it's safe to initiate these. So they need to be initiated as close as possible to the time of menopause, or generally within 10 years. Naturalism-oriented folks may want to talk more about medication. They may be more interested in supplements, food, nutrition, these other things. So luckily there are, researchers across the globe looking at exercise for bone health, conducting well-designed studies. There's a conference coming up at the end of this month on nutritional aspects of musculoskeletal health. So we are getting good data on these types of modalities. But I would say most physicians are not as familiar with these studies and these types of modalities. So we're trying to do a better job of educating healthcare providers about what's effective and what's not effective. But it can be challenging, especially when it comes to supplements. As physicians, we are trained, to look at the blinded randomized controlled trial as the gold standard. The FDA approval is sort of the endorsement that we're accustomed to seeing when we, prescribe a treatment. And so these more natural therapies, we're not going to have those same, standards, those same qualifications. So the challenges for us, for me as a physician, is that, the available evidence may be limited, or I'm going to have to go and seek this information out, read these studies, try to educate myself on these approaches. And again, some of these natural approaches probably are more effective for prevention versus treatment. Once there's established osteoporosis or a history of a spine or hip fracture, for example, there's probably not going to be as strong evidence that these modalities are as effective as the FDA-approved treatments that we have. And then for those with a technology orientation, they may prefer the latest and greatest. So one patient stands out to me. I was describing Tymlos and Forteo. These are both PTH analogs, both daily injections. They work similarly. Tymlos is newer. And she said, well, I want the newer one because if it's newer, it must be better. So, and Tymlos does have some advantages over Forteo. I use both of them. I think they're both very effective medications, but I think that person might have a technology orientation where they are interested in the latest advances. Evenity is the newest medication. People with a technology orientation may be more willing to take the newest medication because they're not necessarily intimidated by the fact that it's newer. Technology-oriented patients will sometimes ask me about vibration plates or other types of devices. And the challenge for some of these things is that when there are really new ideas, new research, we might not have as much evidence or as much data available on the effectiveness of some of these approaches. And then when it comes to believers, as I said before, once a believer makes up her mind on a treatment plan, she does not look back. She proceeds with optimism. I have one patient that comes to mind. We decided on a treatment. I had recommended a treatment and she agreed to it. And then she briefly asked about side effects and I answered her question. And then she said, I'm not really someone who looks up all the side effects. And I thought, this is a believer. She's proceeding with confidence. She's optimistic. Whereas the doubter second guesses a lot. The doubter may spend a lot of time reading about adverse effects of treatment and really wondering if they should proceed or not. So when we're speaking about doubters, that brings us into the topic of biases, which are mental shortcuts. So these are things that can influence our thinking when it comes to making a decision. So one of these is the availability bias, and this is the powerful influence of individual stories on our thinking. And I put in here osteonecrosis of the jaw and atypical femur fracture, because when we look at the data available, it tells us that the incidence of osteonecrosis of the jaw in women on treatment for osteoporosis is 1 in 10,000. But if you've heard of a case, if you know someone who's had it, that may have a powerful influence on your thinking. Similarly, with an atypical femur fracture, the incidence is roughly 1 in 1,000 after between 6 and 10 years of continual use of bisphosphonate therapy. But if you know someone who's had this type of fracture, this is going to have a powerful influence on your thinking. And so that those statistics, although true, may not reassure you. The other thing is that we do not hear about the things that were prevented. So, I sometimes will give examples of patients I've seen who, chose not to take treatment and then come back later with a vertebral fracture, because that's a bias that I see. I see those cases and no one hears about the fracture that was prevented or could have been prevented. And then loss aversion is a bias where the potential loss is perceived as more severe than an equivalent gain. So for example, a side effect of a treatment is perceived as more significant than the benefit of the treatment. So these are things that can influence our thinking when it comes to making medical decisions. So in summary, I would say that we all have mindsets. Patients have mindsets. Healthcare providers also have mindsets. Our mindsets may or may not be aligned, and it's okay if they're not, as long as we're able to communicate and adapt. Well, the healthcare provider can adapt and consider the mindset of the patient. And all of us may change our mindsets over time. For example, Dr. Hartzband gives the example in her book of someone who was a maximalist for treatment and then had an adverse side effect of a treatment and then became more of a minimalist. Or, you could become have historically been a minimalist and then have a new diagnosis that may change your thinking into more of a maximalist mindset. And I can say for myself, I think I started out as more of a minimalist and more of a doubter when it comes to osteoporosis treatments. But over time, as I've been practicing longer and prescribing medications over many years, and also getting older myself, I've become more of a maximalist. I know that I personally prefer to be more proactive with my own health, and I am more comfortable with the medications and more of a believer than I used to be. So things can change over time. So that is all I had. I wanted to save some time for questions. I don't know how to do the poll. I thought it might be fun to poll the audience on how many believers and doubters and minimalists and maximalists we have today, but I'm not sure how to do that. Dr. Nichols, do you know how to do that on Zoom?
I don't. I think it has to be set up in, it would be, my UC Health account.
Okay, well, we'll forget that.
I'll just play with it. Just see if it's.
Well, while you're looking at that, I will take a look at the chat and see if there's any questions.
Okay, yeah, it looks, oh, wait, let me, yeah, go ahead and look,
Okay. Lisa has a question. Is treatment defined as being on meds? Or does it include calcium supplementation? So in those studies that I showed, it's a medication for osteoporosis. So it would not include calcium, exercise, or diet. And the reason for that is because when it comes to preventing fractures, though the medications have been proven to do that, we've never been able to show that calcium supplementation prevents fractures. There's some sub-analyses and some studies that show that, but most of the studies looking at do calcium and vitamin D prevent fractures, they've been negative studies, so the answer was no. Exercise, we do know that exercise can improve bone density, and probably exercise can prevent fractures for many reasons, but we don't have a long-term study looking at the effects of exercise on fracture rates, to the best of my knowledge. Dr. Nichols, correct me if I'm wrong there.
I have only one ear listening to you.
Okay.
Still trying to create this poll, but
never mind.
I think I'll leave that for another time.
Yeah, we'll do that another time.
Yeah, sorry about that.
That's okay. I'll move on. In my experience, this one's from Gabrielle. In my experience, there is not a clear answer based on DEXA results if I have osteopenia or osteoporosis, and if to do anything about it or not, aside from D and calcium. Well, I mean, the DEXA scan should tell you either osteopenia or osteoporosis, but I know that sometimes you can have different scans on different machines that may give different results, especially if you're close to the threshold. So, I mean, those are cutoffs on the DEXA scan. And then if there's anything to do about it, well, that would be a conversation to have with your healthcare provider based on your risk factors, your medical history, and many other things. And again, this is and your values and preferences. So depending if you're more of a minimalist or you're more of a maximalist, there's different ways to go. Okay. Philippa says, interested in the most recent treatment for osteoporosis without a fracture. So most recent treatment, well, the most recently approved medication is Evenity, which is also the most effective when we look at the bone density gains in a short amount of time with Evenity. It blows all the other medications out of the water. It's really effective. But again, would that be the right choice for someone with osteoporosis without a fracture? possibly if they're a maximalist or if they're at very high risk, even though they haven't had a fracture, that might be a good choice. But for other people who are more of a minimalist, that might not be the right decision. Evenity is a once a month injection for 12 months. Okay, what if I am maximalist, but my doctor is a minimalist? So that's a great question.
Great
So that's
question.
why I would love for us all to be educated in this language. And actually, I gave a talk 5-6 years ago for the Stein Institute on Aging that was on YouTube. And I mentioned these mindsets, and I have been surprised at over the years how many people have seen that YouTube video and come to me and said, I wanted to see you because I want you to know that I'm a minimalist or whatever mindset it may be. And it's very helpful to, I mean, this gives us we don't have a lot of time to talk to each other. Everyone knows this. So this is like quickly, I can say, okay, I understand this person's mindset. So I think this would be a great tool if all healthcare providers and patients had this language to communicate. It would definitely help. And I know for myself, I put these things in my notes sometimes. I'll say patient has a minimalist mindset. And then when they come back and I say, why did I choose this or that? Then I'll see what I wrote and I'll say, okay, that's why we only did this, or that's why I prescribed that, because of the mindset. So they don't always align, and that can be a challenge. I guess trying to explain to your doctor that you know that maybe what you prefer is maybe not their first recommendation, but that you're someone who wants to be really proactive. And I mean, as long as it's not contraindicated or, there's no, a physician can only prescribe what they feel is appropriate, but I do think there's wiggle room either way, when it comes to choosing osteoporosis treatment. Okay. Is the Osteoporosis Musculoskeletal Conference later this month available to the public? There is a website. It's called, I don't know. I mean, it's targeted for, I think, researchers and healthcare professionals. But if you wanted to attend, I don't see why you couldn't. It's International Society for Nutritional Aspects of Musculoskeletal Health. You could look that up online. The website is up. The talks will probably be targeted toward a professional audience. So but hopefully we can, Dr. Nichols and I will be there. So maybe we can learn from that and bring some of the information back to this group later this year.
Yes, I believe that they would not restrict the conference to only clinicians and registered. In fact, we can ask, I see that Dr. Weaver.
Dr. Weaver. Hi, she can answer this.
Comment on that?
I think you have it about right. For many people on the call, yours and Jeannie's translation of it on a future meeting will make more sense, because it's at the Hotel del Coronado and registration includes all the meetings and food and whatnot. So it's not a trivial expense.
Yeah.
It's not that you would be blocked from registering up to the maximum amount the hotel can accommodate. But you probably will get more out of it by hearing Jeannie or Gina translate it for you.
Yeah. Yeah, we promise to bring back the key highlights from that conference to you.
There's more participants on this call than we're going to have at that meeting. That's pretty amazing. That meeting is almost all PhD and MDs, except for a few graduate students in training.
Yeah. Okay.
All right. Cindy asks, does a DEXA scan determine your fracture risk or just your bone density? Also, do bisphosphonates build new bone or save, strengthen existing bone? So what a DEXA, well, do you want to take the first one, Dr. Nichols? You're the DEXA expert here.
Yes, we do a fracture risk, a 10-year prediction of fracture. It's a really global. I think there's something like 70-something countries that have a version of, because it's country specific. And so after you get scanned, it takes the bone mineral density from your hip, and then it adds to that 7 of the most serious risk factors for osteoporosis, independent of, and one is have you had a fracture? Also, it gets at the genetics, that parental hip fracture, and then it computes a 10-year risk. All right. So I think most clinics, if you were to go and get scanned at most clinics these days, they add that fracture risk. But I can tell you that sometimes we'll have people come in and they will bring up, what was supposed to be their previous image, and it's a minimalist version of report. You don't really see very much on it. So definitely we do that. Okay, and as far as bisphosphonates building new bone, you take that?
Sure, I'll take that one. Yes, I guess just to add to what Dr. Nichols said, a bone density scan is one piece of information that helps us assess your fracture risk, but it's not the only piece of information. So we consider other factors as well, your age, your fracture history, medical conditions, medications. There's a lot of things that go into the assessment. And then when it comes to bisphosphonates, they inhibit the osteoclasts, the cells that are breaking down our bone. Our body still has osteoblasts that are building bone. What I typically see is that bone density improves in the first few years of bisphosphonate therapy, and then it tends to stabilize. I also do see this varies a little bit depending on the person's age and their baseline bone turnover. That's just my opinion. I tend to see a really good response to bisphosphonates in perimenopausal women who are in a rapid bone losing phase. So this makes sense because their osteoclasts are super active at that time. So when you inhibit those cells, then they really have a nice recovery. Sometimes in, older women, I see more of a stabilization rather than an increase. But they do reduce fracture risk. The relative fracture risk reduction is, about 70% for spine fractures and 40 to 50% for hip fractures. So they are effective. The main thing is you can't stay on them too many years in a row. You have to take those holidays. Okay. Next question from Dolores. Current view of hormone therapy initiated within the first 10 years of menopause, continued indefinitely. Now mid-70s, no fracture history, osteopenia. So yes, hormone therapy is controversial, but it's always, the story seems to continually evolve. We used to use it widely and had never done a study, but all of the observational data looked like it was beneficial, not only for bone, but for cardiovascular health and other things. The Women's Health Initiative study was stopped early in 2002 due to concern for increased harm in the hormone users. We've now had 20 years to analyze that study. Like any study, it's complicated. But what we do know now is that looking at the women, luckily it was a very large study. And so there were enough participants that we could break them down into age groups. And the women who were within 10 years of menopause at the initiation of the study, so starting hormones closer to menopause, there were many, the benefit to risk ratio was much more favorable. In fact, in the estrogen alone arm, the only thing that was more frequent in the hormone users was blood clot. So, that we had over the last 20 years, I think the medical community has really dropped the ball here, and we've done women a disservice by not continuing to teach and research and offer women hormone therapy. So I do use it in my practice, especially for women in their 50s who already have osteoporosis or who want to prevent it, as long as they don't have any contraindications like history of blood clot or stroke or being at very high risk for breast cancer. And then how long you can stay on it, the risks of continuation are less than the risks of initiation. So blood clot risk goes down over time. There's not a deadline where you have to stop it, in my opinion. You may encounter different opinions from different doctors, but especially the low dose patches, I believe, are quite safe and do continue to maintain good bone health. So yes, I have seen women who have been on low dose patch for many years and have good bone health. So as long as, you're being evaluated once a year, risks and benefits are being evaluated, and it's felt to be safe to continue. You know, there's not a deadline, in my opinion.
So Gina, can I add in on that? So
Yes.
the source of the estrogen at the time of the Women's Health Initiative was horse urine. And there were like 200 chemical species of estrogen. And it was always wondered if you didn't take that whole mixture, but some estrogens might not have harmful effects, and you could sort the ones that do. But I haven't really followed that. I don't know if they figured that out, or if the current hormone replacement is still a mixture, or if it's more single estrogen, or what.
Right, great point, Dr. Weaver. So in that study, as Dr. Weaver mentioned, we used Prempro, which is conjugated equine estrogen, and medroxyprogesterone acetate, or for women who had a hysterectomy, just the conjugated equine estrogen. Currently, we use bioidentical 17-beta estradiol. So it's a synthetically produced hormone that is identical to what the human ovary makes. So it's a different estrogen. And we tend to deliver it as a transdermal patch, because when you deliver it as a patch, it doesn't get filtered by the liver like a tablet would. And so the risk for blood clot is lower with the transdermal patches. And then the progesterone that we use now is also different. We use bioidentical micronized progesterone, not the synthetic medroxyprogesterone acetate that was used in that study. So I wonder if the hormone therapy that we have now is safer than what was used in that study, but I don't think we're going to ever get another large WHI study. I don't know, maybe there was just a large bill passed funding women's health. Menopause care is part of that. So maybe there will be more research in this area. But you are correct, Dr. Weaver, that it is a different estrogen. And so it may be safe. The hormones that we have now, I feel like probably are safer than what was used in that study.
Okay.
Okay, someone was the 1 in 10,000. So one case of jaw osteonecrosis. I'm sorry to hear that. I hope you have recovered. Jane says, I hadn't had a fracture in 5 years because I hadn't had a fall in 5 years. When I began to deal with stress reactions in both feet due to osteoporosis, I was ready to start medication. Dr. Woods was willing to work with me until I was ready to start the meds. For that, I am grateful. Now 12 months into Forteo and looking forward to DEXA scan results next month. I hope we get some good results, Jane. And yes, I'm glad that you and I were able to work together for your treatment. Donna says, how long should someone be on Fosamax? Go off, go back on? Great question, Donna. This is an area where the data starts to become kind of sparse. So 2 years off takes the risk for the atypical femur fracture back to the baseline. But then after that, we really don't have a lot of information to guide us. So typically a course of Fosamax would be 3 to 5 years on, 2 years off. After that, you kind of have to just work with your provider and see. Sometimes I do another 3 years on, couple of years off. If someone's at very high risk or just wants to try something different, we have other options now. So this is where the treatment guidelines start to fall apart, because we don't have that much information on after a drug holiday, how long to go back on it. Okay, Linda says, because I am not aligned in my mindset with my provider, only one treatment option was presented. Should I change docs? Oh, Linda, that's a tough one. I mean, you'll have to decide what feels right to you. You could try to use this model to explain where you're coming from. But if you're not feeling heard or not feeling like your provider is going to offer you a treatment that is going to work for you, then you can certainly seek a second opinion. But yes, this can be a challenge.
Gina, just for sake of time, I see we just have 25 new messages and about 11 or 12 minutes.
Oh my gosh.
Maybe,
Wow. Holy moly.
to get it to as many as we can.
Okay.
So. So Evenity, the warning for, MIs and strokes. What do you tell your patients about?
Oh, Evenity. Okay, so Evenity has a warning for possible cardiovascular risk. This came out of so the drug was approved based on 2 large clinical trials. The first one enrolled 7,000 women. Half of them received Evenity, half of them received placebo. And there was no difference in cardiovascular events in either group. The second study was smaller, had 4,000 women. Half of them received Evenity, half of them received Fosamax. So Fosamax was the control group in this study. And there was a numerical imbalance in the number of cardiovascular events. So there were events in 2.5% of the women on Evenity versus 1.9% of the women on Fosamax. So whether that was Evenity increasing the risk or Fosamax reducing the risk or just a chance finding, it's hard to say. Many experts feel it was a chance finding. Although there is some evidence that potentially Fosamax may be cardioprotective, so may have reduced the risk. But there's also reasons that we think, Evenity may be important in cardiovascular health. So the bottom line is we don't know. It does have a warning. I will say at the ASBMR meeting last year, that was the subject of a large clinical debate. And the conclusion of the debate was that there was not sufficient evidence for an increased risk. So it's controversial.
All right. See the next question?
Do you want to tell me the questions, Jean, or should I just?
Yeah, that makes it go faster. So this patient talking about presently on medication, exercise, recommended diet, vitamins, also need prescription meds for other, takes prescription meds for other condition. So she has started conflict on vitamins, when to take, and get mostly through food. I guess that any of us could address that. If you can get the nutrients through food on a regular basis, go for it. The reality is most people cannot or do not. Again, Dr. Weaver is our specialist here in this. If you disagree with that statement, Connie, go ahead and speak up.
No, you're right.
Okay. Then should a dietitian, osteoporosis specialist, or primary care doc be consulted for balancing? Oh, balancing all of those nutrition.
Yes, I mean,
vitamins.
my dream would be to have, my vision for where I would like us to go is to have, for UCSD, to have a comprehensive bone health center where we have exercise trainers who are trained in bone health. There are ways you can get certified and have that available, through your healthcare system, to have dietitians available who can do individualized assessments, make sure you're hitting your calcium targets, your vitamin D, your protein, all those things are so important. We do know certain, eating patterns may increase fracture risk. Vegan and vegetarian eating patterns in some studies have been associated with higher fracture risk. So if someone wants to follow one of those eating patterns, maybe just paying extra attention to make sure you're getting all of your essential amino acids, getting enough calcium, all of that. I would love to have that in addition to all of the effective medications that I can prescribe. But right now we're not quite there yet, but maybe someday we'll get there.
But for now, you could just go on myplate.gov and look for the different patterns that accommodate all the nutrient recommendations and follow it the best you can.
Okay. All right. So we just had someone suggest we do a quick poll via hand raise. See if we can do this. All of those of you who believe that you are lean toward maximalist, just click on hand raise, or just put your hand up. I can see you. We just kind of scroll through these. Actually, it's only going to.
I can't do the hand raise.
Yeah, we're only going to be able to do it with the doing the hand raise icon. Okay.
Yeah, I don't see the hand raise icon.
Reactions at the bottom of the screen where it says reactions.
Okay, got it.
Okay, all right, so raise a hand, and this is doing this on each of my screens, so we're not going to get a good count here. Okay. 6 of 6. All right. Hard to tell. I'd say the jury's still out on that one.
Mhm. Seems like we have a lot, but yeah.
All right,
there's so
my
many
job
participants,
between
it's
now
hard
and
to
next
say.
month is to get the polls set up for us.
Okay.
Okay, yeah. Oh, all right, we get into again, fracture risk, somebody that's familiar with TBS. Joanne, good for you. Asking about medication fracture risk management and how much would having a good TBS score, and it says due to TBS score in parentheses due to lifestyle, exercise, diet. Well, we don't know exactly whether TBS scores, can be attributed to just those things. We know bone mass, of course, does, and likely, but anyway, there's not this direct measured relationship in that regard. But having a good TBS score, which stands for trabecular bone score, and it's an indicator independent of bone mineral density, or BMD, of the quality of the bone, which adds to fracture risk reduction. It's a measure that really only got started relatively a couple years ago in clinics. It's been validated. It's a software package. We do have it. We do include it in our participants, but many clinics do not. Does it contribute to fracture risk prediction? Yes, I'll just leave it at that for now. And I guess Gina, unless you have anything to add right now,
Yeah, I would say it modifies your bone density score a bit, and it's probably most impactful for people who are close to the threshold of
close to the
needing to
threshold.
treatment or not. It might tip you one way or the other.
Yeah, okay, agree. All right, my dentist reticent about doing an implant. What's the newest thoughts on necrosis of the jaw? And then he or she goes on to say, I'm a maximalist and have been on bone drugs for 18 years and have been on Prolia for 7 years. I assume that's Prolia, just misspelled, for 7 years.
Yeah. Well, the studies that we read say it's a 1 in 10,000 risk for patients on osteoporosis. Now, patients on these medications for cancer, which are and who are often taking higher doses and maybe immunocompromised due to other cancer treatments, the risk is much higher in those individuals. So I would say, work with your dentist or oral surgeon and your bone health specialist and try to come up with a strategy. In my opinion, it's safe to get an implant with being on Prolia. You don't need to stop it. You may want to discuss the timing of it, timing of your procedures in terms of your injection cycle, but it can be done.
Okay. Next, if a person has multiple vertebral fractures, can anything really help?
Well, if someone has multiple vertebral fractures, we would definitely want to do a bone health evaluation and initiate some treatment. I mean, first of all, that individual should be evaluated to make sure there's no underlying medical condition that led to the fractures, aside from osteoporosis. But I mean, the fractures will heal. Treatments can help to prevent further fractures. So yes, I would say, all is not lost. We should still do what we can to strengthen the bones.
Okay, next question on reclass, starting reclass, someone that is fearful of taking any meds, strong meds, thoughts on that. And then the next person right after her commented back that she has been on reclass and it's wonderful, no problems for her. So anyway, maybe just any warnings that you would give to this is Marlene about starting reclass.
I feel that Reclast is very safe. We have a lot of information on it. A lot of patients are intimidated by the fact that it's only given once a year, and they feel that if they have a side effect, it's in their system for a year. The truth is, it's not in your bloodstream for a year. It's in your bloodstream for a day, and then it does bind to the bone, and it has a long half-life in the bone. But we want it to. I mean, it's protecting your bones for a long time, and that's why it's convenient that you can only, you can come in just once a year and still be protected. The very common side effect is the flu-like reaction. So that is quite common, often mild, but in some cases severe. So I really warn patients to plan their infusion for a day when they can take it easy for a couple of days in case they get that bad reaction. And it's worst with the first dose. So subsequent doses are generally better.
Okay. All right. Let's see. Do you volunteer for the DEXA school? Do you have to worry about radiation exposure? And the next person, Joanne, who's come to our DEXA school, gave the answer that I would give. Not much. It's equivalent to 1 day of sun exposure in Southern California, or a cross-country flight from LA to New York. Okay, that would be the dose of radiation to which you're exposed. So really no more, well, let's just say a teeny bit more than you would get if you just had a spine and hip that your physician would likely order. But because it's the school and the techs have to be trained in all images that are usually, that are typically, not typically done, but that may be done in the clinic. You get spine, hip, forearm, and a whole body scan for body composition, which a lot of people really like because you can track your muscle, lean tissue mass, as well as fat mass over time. Okay.
Dr. Nichols, I'm afraid I'm going to have to wrap it up here. I do have clinic this afternoon, so
okay, so yeah, lots of questions here. I'm going to.
if you want to continue to take them, I'm going to have to sign off. But thank you all for joining today.
Okay, thanks, Dr. Woods, so much. We really appreciate it. I tell you what, I can stay on till I have a 1:15 meeting, and I will avoid addressing direct medical questions that I really draw the line between what I'm trained in versus a physician, but I can maybe address some of the others. So those of you who have a burning question, want to stay on, feel free to do so. Everyone else, thanks for your attention and your attendance. And we look forward to next month. We don't have the title of the talk. We do have a speaker, but not the title yet. And then just one word on Trumba. Right now it's showing sessions in July and August. We do not meet in July and August. We go on the university's calendar for the academic year. So July and August, we will not meet, and then we resume in September. Okay. All right. So with that, again, feel free to log off, and I'll continue to go through this. Someone just asked about TBS. I think Dr. Woods addressed that. The bottom line on TBS is that it probably serves the best purpose, as she said, for those who are kind of on the threshold of, do you need more medicine, need to go on a med or not. TBS helps the clinician make those decisions. That's what our bone specialists have instructed me to let people know. Okay, so as far as using Evenity and Forteo at the same time, I'll skip over that. It's probably not, but there may be instances that I'm not aware of. Okay, and thanks for getting a few suggestions on how to do a poll. So I promise I'll come back next time knowing how to do that. what happens after a year on Evenity, no further treatment. In general, what I'm hearing if clinical sessions in seminars that I attend regularly is that physicians should be telling their patients that osteoporosis, sort of like blood pressure, this is a lifelong, you're probably going to need to be treated for life. It's not you go on something, you're off, and then never again. But specific drugs have different amounts of time they're recommended to be on or off. And usually when you transition off a medication, for example, the most heavily prescribed medication is bisphosphonate, Fosamax, and it's alendronate is the generic name, and that is usually prescribed initially for 3 to 5 years. And then patients are usually advised to go on a drug holiday for anywhere from 1 to 2 or 3 years, and then repeat. And that's because Fosamax stays in the system, stays in your bones for a long period of time. And it usually takes a while before your bone mass will deteriorate. But actually, most of that happens fairly early on, just that sudden change. But there's some maintenance. The reason for that 3 to 5 year drug holiday, in different clinicians will have slightly different viewpoints on that. This is sort of in general. The reason is because of the one big study that was done in Canada. We actually had the speaker who was involved in that study, who led that study actually. She spoke to our group a couple years ago and trying to get her back to talk more about drug holidays again. And she showed a beautiful graph that showed that after up to 2 to 3 years post Fosamax, the increase in they were looking specifically at atypical femur fractures, and there was essentially no increased risk. Then right around that 3-year time, the curve started to go up just a little bit, and they measured this out, I believe, for 12 years, but it was still a very small increased risk. Where it started to curve upward a little more steeply was after 5 years on the drug. And so that's where this 3 to 5 year drug holiday has come from. Still, it was fairly low. And then after 8 to 10 years, higher. So it gets down to, benefit versus risk and weighing that out. But most clinicians will suggest drug holidays for the bisphosphonate drugs. Okay, I said I wasn't going to talk about drugs, but used in that generic way. So now, okay, so Ellie's, I think I just addressed Ellie's mind. So, okay, Maya's DEXA scan, it's 81 for, yeah, okay, so finding that T-scores, which is the diagnostic threshold of -2.5 for osteoporosis, first time having a DEXA scan, finding out that scores are quite low, it is kind of, wow, what happened? In some cases, it might not be something that the patient has been doing just in the more recent past, but going back, and we don't know this, but it might be that person just during their growth years attained a peak bone mass that was appreciably lower than the average. So everything's based on the average peak bone mass of a 20 to 29-year-old, female, basically, all judged against a female reference population. So don't know unless that person was somehow involved in a study during their youth. So if you achieve a peak bone mass, let's say 10% lower than the average, then even if your trajectory of changes in your bone health remain the same as for someone that achieved a higher, an average, 10% higher than you, at any given age, you're going to be 10% lower. So of course you're going to get to, say, the menopausal years or the and beyond, where you're going to be diagnosed with osteoporosis at a younger age. Okay, 10% reduction is quite significant. Right? So that might be the reason. Can't change that. You can only go forward with it. Okay. So what about if TBS decreases, but bone density score has improved? More at risk for fracture because TBS has decreased. All other things being equal, the answer is probably a minimal yes on that. Again, all other things being equal, which they never are. So hard to say why TBS would decrease where BMD has increased, unless that if the person's being treated, with a bone medication, you'll see a more rapid change for the better in BMD than you will in TBS. So it might be something to do with that. Yeah, again, multiple vertebral fractures. This is a tough one. Guess one thing in our program that is our exercise program that focuses more specifically on fall and fracture prevention through falls, and heavy emphasis on postural training and balance and mobility to prevent a fall. And I always use, throw out the statistic that hip fractures are, it's something like 95% of hip fractures are caused by a fall on the side, on the hip. So if you can prevent a fall, especially to your hip, you can, almost completely remove the risk for hip fracture. So that's a big if. So, but clearly, if you can do everything possible in terms of behavior of preventing a fall, then you're going to be so much lower risk of preventing fracture. Okay. So it's getting a lot of is it advisable for male individuals been diagnosed with osteoporosis to get a knee replacement, or is the outcome of success significantly reduced by the osteoporosis? So this is David, and I, really good question. It's been encouraging to see, and this is very true at UC Health, to see a cooperation between endocrinologist, the bone specialist in treatment, and the orthopedics department. I think under the direction of Dr. Susan Bukata, who's new director of Department of Orthopedics, she is really making moves to first of all, know what a person's bone health is, prior to an elective surgery, and then, work with that depending on how much time is elapsed. I believe that many clinicians now are advising patients in cooperation with the orthopedic surgeon to have the patient go on a bone medication for so many months up to the surgery, if indeed there's enough time there, and the surgery isn't, absolutely necessary at that moment. Okay, so I think we're going to have lots of improvement in that whole idea. I do know that sometimes bone, this more with hip replacements, that if the bone is so susceptible to fracture that it putting the implant in is often there's problems with that in itself. So it's a really tough call. So again, it all goes back to trying to do more prevention. Indeed, if you've been advised to consider joint replacement, really consult with your clinician to get cooperation and recommendations what to do about your bone, your level of your BMD prior to. Okay, other surgery, bunion, if osteoporosis will bones heal. Yes, bone have an amazing ability to heal, but every surgery is unique in this regard. And so I think my best advice is that you ask and really almost demand the orthopedic team consult with either your primary care or endocrinology, if indeed you've been seeing a specialist, and come together on a plan, pre-op, before you actually, commit to the surgery, that the possibility of a good outcome is greater. Okay. Need an option for in the middle, maximalist or minimalist. Yeah, no response really there. I think probably that's where we kind of like to be, not at any of the two extremes. Let's see, Helen, a hand up. Helen, are you still here? HWP, did you have your hand up? Maybe she's off by now. Okay. Okay, so no.
Thank you.
Oh, you are here.
Yeah, no, it's okay now. It just got answered and I didn't lower it yet. So thank you. It's about the surgery if you're you have osteoporosis and on medication, and how to get the team. So it's great to know that UCSD has UC Health has the team now coordinating with that. Thank you.
Yeah, you're welcome. Okay, I think oh my goodness, I have to get on a meeting here too. So I'm going to save these chats, and I can try and get many of these questions answered. Some of them I can address, but I think for the most part they are medically related. So we've talked about having just a big kind of Q&A to end the year. We bring a couple of different specialists together, and we just have a big Q&A. So if that's something that interests you, you could message me on by Trumba or by my UC Health email, and we can work on that. Okay, and several thank yous to our doctors, and also thank you, Dr. Weaver. I just happened to see her face there, and right at the time we're asking about the conference. She is heading up that conference that's coming up. So, all right, everyone, must sign off now. Thanks for your attention and your interest, and stay healthy and well, and we will see you next month. All right, bye-bye.